Welcome to the Gray Bryce IPAC Hub presentation on antibiotic-resistant organisms in healthcare settings. This presentation was provided to the long-term care IPAC leads within Gray Bryce on Wednesday, April 12th via Zoom meeting. Here's a brief outline of what we hope to cover today, and please feel free to reach out to the IPAC Hub with any questions or concerns you may have. Fact: according to the CDC, antimicrobial resistance is an urgent global health threat, killing at least 1.27 million people worldwide, and was associated with nearly 5 million deaths in 2019. In the US, more than 2.8 million antimicrobial resistant infections occurred each year, and more than 35,000 people died as a result. This was published in the CDC's 2019 Antimicrobial Resistant Threats Report. What is antimicrobial resistance? Antimicrobial resistance happens when germs like bacteria or fungi develop the ability to defeat the drugs designed to kill them. That means the germs are not killed and continue to grow. Resistant infections can become difficult and sometimes impossible to treat. It is important to note that bacterial resistance has been around since the 1940s, and some bacteria have inherited or natural resistance to certain antibiotics, while others acquire resistance to antibiotics from new pieces of genetic information. Acquired resistance is the type of resistance that is of concern because these bacteria can continue to change and develop further resistance. Heavy use of antibiotics, both in medicine and in agriculture, is the factor in emergence resistance. The more exposure bacteria have to antibiotic, the more selective pressure there is for them to continue to grow and develop. Some of the more common AROs that we receive questions about from homes include MRSA, VRE, ESBL, and CPE. But there are others that we should be aware of as well, such as Candida aureus and C. difficile, and then you can see the rest here. In 2019, the CDC presented the following list of antimicrobial resistant threats, classifying them under urgent, serious, concerning, and a watch list. This brings to light the importance of surveillance programs, ensuring that facilities establish baseline, and implementing the appropriate routine practices and additional precautions such as hand hygiene for staff, resident, and visitors, as well as environmental cleaning and the need to look closer at antimicrobial stewardship overall. The reason behind emergence of new drug-resistant strains does not fall only to healthcare. It also involves the increased global trade and travel, the use of antibiotics in intense animal husbandry as prophylaxis against infectious diseases, or for the growth, promotion, and the direct transmission from animals to farm workers, resulting in the use of further antibiotic use. It is important to look at AROs because they do impact our residents. They negatively impact our residents' mortality and morbidity, the patient outcomes, their quality of life, their quality of care, and increased hospital stays, and can also give our residents a feeling of isolation and loneliness. So what can you do? We can, and you can educate staff on the appropriate precautions. Ensure they know what an ARO is, how is it spread, what precautions should I take, how to perform a point of care risk assessment, followed by implementation of and maintaining hand hygiene programs that includes the appropriate point of care placement of hand hygiene products at the bedside as well as exit to resident rooms. Your hand hygiene programs already include auditing as well as education, but giving feedback to staff as well. Also ensuring that staff have access to PPE at point of care, and overall just looking at your program in general. Assess, plan, and implement antibiotic stewardship within your facility. How are AROs spread? AROs can be transmitted by person-to-person contact or by indirect contact when surfaces of items in healthcare environments become contaminated. As a result, such contact healthcare workers and/or patients may become colonized or infected with an ARO. and be a potential source for spread to others. The single most important mode of transmission of AROs in healthcare settings is via transient colonized hands of healthcare workers who acquire it from contact with colonized or infected clients or residents handling contaminated materials or equipment. The unrecognized colonized patient, resident, or client presents a particular risk for transmission to others within your facility. It is important to note that as a part of the Long-Term Care Home Act, that you are required to have a policy and procedure in place to review ARO surveillance screening, identify residents at a high risk for colonization, ensure that you have process in place for routine practices and management, also management and treatment of AROs, having staff and visitor education regarding AROs, establishing baselines within your facility and encouraging further surveillance data will help determine outbreak status moving forward within your home. As mentioned, establishing a baseline within your home for infection is important. Baseline data provides the home with a starting point. This allows you the ability to identify potential issues or outbreaks when you start seeing numbers above baseline. Baselines are collected through surveillance, tracking, and monitoring, screening in some cases, and also comparison points to other facilities locally. The following chart is available through the Public Health Ontario IPAC document and outlines patient risk factors for some of those common AROs that we see within facilities. Residents who present with an ARO are required to be cared for under contact precautions. So ensuring appropriate signage and PPE is placed out for those residents is extremely important to minimize risk to other residents within your facility. MRSA. Staph is a very common germ that about 1 out of 3 people have on their skin or in their nose. They do not cause an issue for most, but in some causes, skin and wound infections, pneumonias, infections of blood, sepsis, and even death. Antibiotics are given to kill staph germs when they cause infection. Some staph germs are resistant to several antibiotics, meaning that those no longer able to help with that infection. So it's important to make sure that we identify MRSA and ensure that appropriate precautions are in place. ESBL. So ESBL is another one of those ones that we have going on in our facilities quite frequently. So ensuring that you have residents in contact precautions with appropriate PPE. Also making sure that there's some considerations if you have a resident with catheter care considerations, as well as the environmental cleaning and hand hygiene. Whenever possible, those residents should be cared for in a single room accommodation. CPE. Again, this is another one that's becoming more and more urgent or emergent, I should say, and difficult to treat because they don't respond to commonly used antibiotics. So it's important to make sure that we're identifying this if you see it. Candida aureus is also emerging. It's a fungal pathogen, and it's resistant to several different medications. So it's important to identify this as well. And you can see here a little bit description on Candida aureus. And then there's the Visa, the VRE, and the VRSA as well, which you can read here. Antibiotic-resistant organisms do have an ability to discontinue contact precautions or decolonize our residents. So here is an outline chart from Public Health Ontario on how you would do so in terms of whether it be MRSA, VRE, CPE, or ESBL. Decolonization is not something that's commonly recommended. However, they do have information here outlining that. Pathogen reduction and decolonization methods include different treatments, such as topical treatments, antibiotic prophylaxis, and/or nasal ointments for the nose. So current evidence does not recommend MRSA decolonization therapy as it may promote antibiotic resistance further. And long-term efficacy is poor, and systemic therapy may lead to adverse events. So just as an FYI, it's just really looking at your client and what's best for them. Our next IPAC presentation through the Grey Bruce IPAC Hub will be held on May 10th at 9 a.m. for our IPAC leads. And at that time, we're going to talk about antibiotic stewardship. So this is furthering our conversation just to assist with AROs and overall treatment within our facilities. So there is antibiotic overuse in Ontario's long-term care home. As you can see here through their infographic, it is from pre-pandemic, so I'm sure this has changed. But we are overusing antibiotics overall in terms of our resident care. And this is just continuation of the actual infographic. So in terms of antibiotic stewardship programs and core elements are in the hospitals currently, they include tracking, reporting, accountability. So appoint a single physician lead as a responsible person for that program's outcomes. Looking at measures, so antibiotic timeouts prior to authorization for antibiotic use, auditing and feedback. Automatic changes from IV to PO, that might not necessarily be the case within your facility, but these are some of the measures that hospitals take. But ultimately, you are going to need the leadership's commitment. So dedicated, necessary human resources, financial and information technology resources, as well as the backing of your physicians, your EDs, your pharmacy, all of those individuals. And ultimately, the education is extremely important for optimal prescribing. Some of the references to the program or this presentation today include the CDC's report, some of the CDC information, as well as Public Health Ontario. If you have any questions or concerns, please reach out to the IPAC Hub at ipac@publichealthgraybruce.on.ca, and we'd be happy to help you. Thank you and have a great day.